So today I'm going to go over chapters 8 and 9. So the first chapter for 8 is nursing care of women with complications during labor and birth. So there's a few different obstetrical procedures that can occur when there are complications, one of them being an amnioinfusion. So that is when fluid is actually being going in for one of the reasons being oligohydramnios, which means that there's not enough amniotic fluid. So there's a way to do that through, it's called an IUPC, which is an intrauterine pressure catheter. Another reason would be cord compression, when there's a lot of variables going on, dilution of that meconium stained fluid. So basically what it does is replaces that cushion for the umbilical cord and relieves those variable decelerations. So two things that can be done when someone is either in labor or not in labor. There's induction, which is the initiation of labor before it begins, or augmentation is when it's stimulated when the contractions, someone's in labor, they go to the hospital, they start to peter out a little bit. So there's things we can do to augment that labor. Some reasons that this needs to occur for an induction of labor. These are just a few of them, but there are more. Gestational hypertension, rupture of membranes without that spontaneous onset of labor, infection, medical problems, placenta insufficiency, or if there's fetal death. Reasons why labor should not be induced. Here's just a few: umbilical cord prolapse, high station of the fetus, placenta previa. So all of these reasons are because these patients should not be in labor and they actually should be having a C-section. So here are some different medications that can be used for induction and augmentation. Cervidil ripening is used for induction. And the picture of what that looks like, it's just that string and there's a gel on there, and that's inserted into the vagina and applied before labor induction to soften the cervix. And then oxytocin, also known as Pitocin, can be used for an induction or augmentation. So it's used to initiate or stimulate contractions, and it is the most common used method. Another is Cytotec, and that can be given PO or intravaginally. So this one is used to help with contractions as well. The problem is sometimes what can occur is uterine tachysystole, which is when there's too many contractions going on. It is an off-label use, but it has been approved by the American College of Obstetrics and Gynecology. And then Cervidil is the other one used for that as well. So what are you going to do to help prepare the woman for induction or augmentation? Obviously, you're going to explain what's going on, obtain baseline vital signs and fetal heart rate. You want to make sure that there's an IV placed or a saline lock. When they have Cervidil placed, they should be staying in bed for 2 hours. This is so once they get up, sometimes it may fall out. So you want to make sure they're getting at least 2 hours of that medication. Oxytocin induction normally starts about 6 to 12 hours after the cervidil has been removed. And then you want to make sure that you're assessing for the signs of uterine tachysystole. Another procedure is an amniotomy, and that is the artificial rupture of membranes. So that's done to stimulate or enhance those contractions. So when this is done, it commits that woman to delivery. So she can't be like, oh, actually, I want to go home and see if I can labor on my own. It's like, okay, once this happens, you're going to be having a baby. So some complications, we've talked about this before. So that prolapsed umbilical cord is one of them. Another one is infection. And then something that can occur as well, but is rare, is that abruption. So because of the risk of infection, the maternal temp should be taken about every 4 hours after those ruptured of membranes. So you want to make sure that you are changing those pads for the woman when they're in bed, because it just can get really uncomfortable for them, especially if they have a lot of fluid, and can lead to infection and skin breakdown. The question number, you are assessing characteristics of amniotic fluid post amniotomy. You observe the color of the fluid to be green tinged. This can indicate the potential for, the answer would be 4, fetal distress. So here's a picture of what it looks like to be tachysystole when there's an overstimulation of contractions. If you see on the bottom there with the contractions going, it looks like every 1 to 1.5 minutes. So that's too much going on. So what do you do for interventions when there's uterine contractions for oxygen or oxytocin? You want to notify the provider, position change, decrease the dose, make sure that there's IV fluids going. The patient may need an IV bolus. Give O2. This can occur, but it's not going to be your first intervention because it does affect the infant. So you would want to do more of the position change, notifying the provider, decreasing that medication, giving IV fluids, and then if none of those are occurring, then you could give O2 if those heart tones are still not looking the greatest. Another thing that can occur is an aversion. This is when an infant is breech and the provider can externally turn the infant to a vertex position. It does not happen always. It's more of depending on how much fluid is in there, how the baby is. There's a lot of different factors that go into place before a provider will do a version. And then sometimes what happens is it's a successful version, and then 2 weeks later, the baby might flip back to breech. So that can occur as well. Another thing that a provider can do is an episiotomy and then lacerations. So an episiotomy is what the provider does, and it's a controlled surgical enlargement of the vaginal opening, whereas lacerations are uncontrolled, so these just tear on their own. So there's 4 different degrees of the lacerations. First and second degree are normally fine, may just need a few stitching. Third degree is a little bit more severe. And then fourth degree is actually, it extends all the way to the anal sphincter. So that one is pretty major. They may need to have surgery to fix that. And a lot of times they won't deliver vaginally with their other deliveries because of it. So here's just a picture of what an episiotomy looks like. There's the midline, and then it can be either done right or left. So what are some reasons for an episiotomy? There's better control over where and how much the vaginal opening is enlarged. So this helps prevent a fourth degree. Another thing that may need to occur when the infant is through the birth canal, maybe needing a little bit more help, is either a forceps or a vacuum delivery. So forceps is when the provider uses, and there's a picture right after this, traction and rotation of the fetal head when the mother's pushing. And here's a picture of what that looks like to help get the baby out, so that way they don't need to go to a C-section. And then here's a picture of vacuum extraction birth, where it actually uses suction on the head and then is pulled when the mom is pushing as well. But this can lead to quite a bit of coning with the head, and then also a cephalohematoma can occur as well. So risks are going to be trauma to the mother or fetus. Mom may have lacerations or hematoma, and then the infant may have bruising, a facial or scalp lacerations or abrasions, and then that cephalohematoma. Also, an intracranial hemorrhage can occur as well. Okay, and then going to cesarean birth for reasons why a mom can't have a vaginal delivery, decreased fetal heart tones, lots of different reasons why someone may need a cesarean birth. So C-sections account for more than 32% of all deliveries in the United States. Here are some reasons why. Abnormal labor, maternal complications, active herpes, fetal compromise, or placenta previa or abruption. Risk of C-section is going to be the medications they're getting from anesthesia, hemorrhage, respiratory complications, delayed and infection. Preparation of the cesarean birth. You're going to be looking at labs beforehand, look at the CBC, blood typing, making sure they have an IV line, Foley catheter inserted. Types of incisions. There's the vertical, always more room for a large fetus, and then there's the transverse, and I'll show pictures of that in the following slide. And then uterine, there's lower transverse, low vertical, and then classical. So the classical is going to be more for emergencies, or if the infant's really like a 25-week gestation. So here's a picture of the different incisions with your lower transverse versus your classical. Sequence of events, what's going to be occurring during a C-section. Administering the medications, cleaning and draping the mother, making the incision, making the uterine incision, rupture membranes if it already hasn't been done, completion of the fetal head, and then suctioning, and then clamping of the cord. So what's the nurse going to do in the recovery room? Get vital signs to, obviously to make sure that they're doing okay, but also to make sure they're not having a postpartum hemorrhage or shock. Assessing the IV site, massaging the fundus, assessing the dressing to make sure it's not bleeding too much, assessing the lochio, and then also urine output from the catheter. So although assessing the uterus can be uncomfortable, it's important to make sure that you still do it. And the woman may have a relaxed uterus that causes excessive bleeding regardless of how she delivered her child. Okay, now we're going to be looking at some of the reasons why there's an abnormal labor. So it's called dysfunctional labor, which does not progress, and then dystocia is difficult labor. So risk factors for dysfunctional labor: advanced maternal age, obesity, overstimulation of the uterus, maternal fatigue. So this is just a list of a few of them. So problems with the powers of labor. It can be hypertonic. So that's when there's increased muscle tone, when that patient is contracting too much. So that can be painful but non-productive. So the uterus is tense even between contractions, but they're not strong enough to make any change for the patient in labor. And then there's hypotonic, which is decreased muscle tone. And that is when those contractions just kind of diminish during labor. And then there's ineffective maternal pushing. The mom may not understand which technique to use, or fears tearing of her tissue. Epidural may eliminate that natural urge to push because they don't have that feeling to do that. Or there may be problems with the fetus. Might cause that labor progression to be dysfunctional. Includes the size, presentation, and positioning. So fetal size, macrosomia. Large fetus may not fit through that birth canal. Then there's shoulder dystocia. Usually occurs when the fetus is too large, but not always. This is considered an emergency. So it's that fetal chest cannot expand and the fetus needs to be able to breathe. So what this is when that head comes out but the shoulders are stuck. So they are at more risk for uterine atony and postpartum hemorrhage after this as well. And the infant may have a fractured clavicle, but they actually recover pretty quickly from that. So abnormal fetal presentation or position prevents the smallest diameter of the fetal head to pass through the smallest diameter of the pelvis. So those abnormal presentations, it just does not pass easily, can cause cord compression, may require an external version, lots of different reasons that can occur. And then abnormal positions. Common cause is a fetus that remains in a persistent, it's called OP position, so that's when that infant, the head is facing up, and they call it like sunny side up when the infant is born. Maybe labor may last longer, and they may need to have forceps for delivery. So here's a picture of what it looks like to have a breech birth. As I talked about in class before, not all providers will do breech, but some will, depending on their experience. So what's the nursing care for abnormal fetal presentation or positions? A lot of its position changes. So if they have a lot of back pain from it too, have them be in a sitting or kneeling, standing position, hands and knees, rocking the pelvis back and forth, just doing lots of different position changes to try and help that infant move. And then another reason for dysfunctional labor is when there's multifetal pregnancy. So there's uterine overdistension, contributes to poor contraction quality, abnormal presentation. Often one fetus is delivered cephalic, and then the second one is breech, unless the version is done. Here's a picture of what it looks like on the monitor for twins. So you're going to see heart tones for both infants. This one is not in sync, but sometimes looking at it, they are very in sync, which is actually kind of cool to see. So problems with the pelvis or soft tissue. So we talked about the different types of pelvis, of which ones are more favorable for birth than others, and then soft tissue obstructions. The most common is a full bladder. So full bladder can cause labor dysfunction, and so that may need to be straight cast. Okay, another reason why is the psych. So here are some of the most common factors that can prolong labor when it comes to psych. Absence of support, immobility or restriction in the bed, lack ability to carry out cultural traditions, or lack of pain control, increased anxiety. So increased anxiety causes hormones to be released and then reduces contractibility in the muscle, smooth muscle. So the uterus uses more glucose for energy and diverts blood from the uterus, increases tension in the pelvic muscle, can impede fetal descent. So what can prolonged labor cause? Maternal or newborn infection, maternal exhaustion, postpartum hemorrhage, and then increase a greater anxiety and fear. Okay, so now going to the opposite of prolonged labor, we're looking at a precipitous birth. So that is a birth that is completed in less than 3 hours. Labor begins abruptly and intensifies quickly. This can lead to a uterine rupture, cervical lacerations, or hematoma. Fetal oxygenation can be compromised. And then injuries can include intracranial hemorrhage or nerve damage. Another thing that we've talked about in class or in lecture or in simulation lab is premature rupture of membranes. That's what that spontaneous rupture of membranes a term, more than 1 hour before labor contractions begin. So this can be diagnosed through nitrazine paper test. So that is just looking at the pH on a piece of paper, and if that pH, if that piece of paper turns blue, then it's saying, okay, you may be ruptured. But there are a lot of things that can cause a false positive, just because all it is testing is pH. So if a patient had sex recently, sperm can actually change that pH. So there's lots of different factors. So rule of thumb, it's good to do multiple tests to make sure if you're not sure if the mom is ruptured or not. Another thing that can be done is it's called burning. It's taking some of that fluid, putting it on a microscope and looking at it and underneath the microscope and what you'll see are little crystals, almost like when you go out to your car in the morning and there's frost. That's what it looks like. They have little snowflakes on it. Another test that can be done is amniosure, and that's sent down to lab to test. But there are also things that can be cause a false negative or false positive with that as well. Okay, looking into preterm labor. So this occurs after 20 weeks, but before 37 weeks of gestation. So what are you going to do for patient teaching for a woman with infection or preterm labor? Because one of the reasons someone can be in preterm labor is infection. So you want to report that temperature, avoid sexual intercourse, maintain any activity restrictions prescribed, and then note any uterine contractions, reduce fetal activity, and other signs of infection. So here's some risks for preterm labor: underweight, dehydration, preeclampsia, chronic stress, infection, anemia, smoking, lots of different reasons why someone may go into preterm labor. So signs of impending preterm labor: a shortened cervix by ultrasound. Also, something called a fetal fibronectin test, and that is the presence of fetal fibronectin in vaginal secretions between 22 and 24-week gestation is predictive of preterm labor. But that doesn't mean, so basically they're more likely to go into preterm labor, but it doesn't mean that they're going to. Someone who is negative FNT pretty much means that they're most likely not going to go into preterm labor. So some signs and symptoms: contractions that may either be uncomfortable or painless. They may just have cramping, constant lower backache, or they may just feel bad or coming down with something. So the whole goal is to stop those contractions, keep fetus in utero until lungs are mature enough to adapt to external life, have magnesium sulfate. So we talked about this in lecture and mainly in simulation lab, we've talked about magnesium sulfate. So it's to help with neuroprotection, one of them being cerebral palsy. Terbutaline is a common medication used to help stop the contractions. Those are beta adrenergic drugs. Calcium channel blockers also may be used. Not as common, but if they are used, you don't want to mix that with the magnesium sulfate. So initial measures to stop preterm labor: identifying and treating the infection or the reason why they're in preterm labor, activity restriction, and then hydration. If it appears preterm labor is inevitable, you want to give those steroids that we talked about, one of them being the betamethasone IM. So prolonged pregnancy, that's the opposite, so it's lasting more than 42 weeks. Placenta ages, so there's delivers oxygen nutrients to the fetus is less effective, so that's fetal skin may peel. So then the fetus will continue to grow, so there's more risk of macroscopic infant, higher risk of meconium stained fluid, and then low blood glucose levels in the fetus. So any pregnancy that lasts longer than 40 weeks may require more frequent non-stress tests, amniotic fluid index, which is just looking at how much fluid is there, a biophysical profile, and then also kick counts. So emergencies during childbirth. We talked about these as well: prolapse umbilical cord or uterine rupture. So here's a picture of what that can look like with a prolapse umbilical cord on B, C, and D. And then here's a picture of uterine rupture. Can happen because of someone trying to labor, doing the VBAC or the POLAC, child labor after cesarean, blunt trauma, or also if there's doing an induction or augmentation of labor. So what can occur if an uterruption actually does happen? Shock caused by bleeding in the abdomen, abdominal pain, pain in the chest, contractions will be done, abnormal or fetal heart tone rates, and then palpitation of the fetus outside the uterus because the fetus has pushed through the torn area. Something else that can occur is an amniotic fluid embolism. This occurs when amniotic fluid, with its particles such as vernix, fetal hair, or sometimes meconium, enters the woman's circulation. This is characterized by abrupt onset of hypotension, respiratory distress, and coagulation abnormalities. So treatment of amniotic fluid embolism. So you want to give mechanical ventilation, treat shock, replace coagulation factors with platelets. You may need to give packed red blood cells, strict INO, doing a pulse oximeter, cardiac monitoring, and then transfer to ICU. So in this scenario, you would do oxygen first and mechanical ventilation with your airway breathing circulation. All right, so now focusing on chapter 9, we're looking at the family after birth. So here's just a picture of just two different types of families that may be going through that you'll be taking care of. You have the one on the left that shows a couple that they're really excited for this. This may be their third baby. They're like, we've got this, we've done this before. Whereas that other picture is maybe first time parents that have no idea what they're doing and they're having a little bit of anxiety going on. So when you're taking care of a patient postpartumly, you want to look at, the culture. So the nurse, that want to adapt and doing their fit with health benefits, values, practices, looking at dietary practices, and then focusing on the postpartum changes in the mother. So immediately after delivery, the mother experiences multiple psychological changes. So it's important for the nurse to assess all body systems and not just focus on the reproductive system. So on the reproductive system, that uterus is going to be changing. You either want it to be firm, or if it's boggy, which means that uterine atony, that uterus is not contracting the way that it should, it needs to be massaged to try and firm up. So then you're looking at lochia. So in the beginning, it's going to be rubra, which is that dark red, and then serosa is kind of like that light pink, which will change through time, and then eventually when they're at their 6 weeks postpartum checkup, it should be alba, which is white. So there's going to be lots of changes. There's going to be assessing the perineum, assessing for if there's episiotomy or lacerations. It's important for the patient to have cold packs to help reduce the swelling, and it helps with pain. And then return of ovulation and menstruation. So the menstrual cycle typically resumes in 6 to 8 weeks if not breastfeeding. And then return of ovulation is delayed if breastfeeding. However, it can occur at any time after birth. Okay, so during postpartum teaching, a woman expresses that since she is breastfeeding her newborn, she will not require birth control. The nurse will inform her that breastfeeding is not a form of birth control. Answer number 3. So the breasts are going to become engorged, and nipples should be assessed for redness and cracking, and then a supportive bra should be worn. So the urinary system. A full bladder can dispose the uterus and lead to a postpartum hemorrhage. So you want to make sure that bladder stays empty. A woman who avoids frequent small amounts of urine may have increased residual urine because her bladder does not fully empty. Residual urine in the bladder may promote the growth of microorganisms and increase risk of a UTI. Gastrointestinal, they're more likely to be constipated. So to help alleviate this problem, you want to encourage them to increase their fluid and fiber intake and also increase their activities such as walking. Immune system, prevent blood incompatibilities, infection. They'll need RhoGAM if the mom is Rh negative and baby's Rh positive. We've talked about this already. And then adaptation of nursing care following a C-section birth. Some of it's going to be the same and some is going to be a little bit different. So differences, you're going to be monitoring that abdominal incision, just like you would with a surgical patient. They are more likely to have less lochia. They'll have a urinary catheter in place. You want to be checking for their respirations and then also having them use an sense spirometer to help in doing cough and deep breathe. And then pain management as well. So you want to assess their emotional care. The birth of an infant brings about physical changes in the mother, but also causes many emotional and relationship changes in all family members. So the mom may get postpartum blues, postpartum depression, and fatigue. So which of the following groups of signs and symptoms are most representative for postpartum blues? And the answer is 2. Crying, loss of appetite, difficulty sleeping, and anxiety. So then you have the grieving parents. This would be if their infant ends up having a stillbirth, if delivers prematurely, needs to go to the NICU for a long time and is really sick. They may go through those different grieving process of shock, anger, guilt. So here's some information you want to collect for family care plan. This is going to be postpartumly before discharge. You want to make sure that they have a crib at home, that they have a car seat, that they're going home to a safe environment. So kind of reviewing all of those things going on before discharge. So focusing a little bit on the baby, that transition to extrauterine life. So there's different phases. Phase 1 is period of activity. Phase 2, a lot of times they'll be sleepy, and then phase 3, they will be back to reactivity. So on most units, all caregivers are going to have that pink badge. So maybe a little bit different depending on the floor, but most are pink. And so those are the only people that should be taking the infant out of the room. And whenever that infant is brought back, the infant IDs and mother and father IDs should be checked to make sure that they match, so you don't run the risk of mixing up babies. Because obviously it's happened before, which is why this is in place. So care for the infant. You want to obtain vital signs. You want to assess for any injuries or abnormalities. Umbilical cord care. You just want to make sure, a lot of times they'll just put some alcohol wipes on it. Screening tests that need to be done, and we'll focus a lot on that with the simulation lab that's going to go over all baby things. So something that can occur is hypoglycemia. So that's a blood sugar below 40 in a term infant indicates hypoglycemia. So risk for neonatal hypoglycemia. Lots of different factors. Here are just a few. Preterm or postterm, diabetic mother, IUGR, cold stress. So what are some signs and symptoms? The infants can be jittery, sweaty, poor suck, high-pitched cry. They may have seizures. So then focusing on breastfeeding, choosing whether to breastfeed or not. That is ultimately the patient's choice, but there are a lot of benefits to breastfeeding, but not all patients choose to, or some can't. There's different phases of milk production. There's the colostrum, which people call that liquid gold, and then transition, and then to mature, which is the normal breast milk. Here's a picture of what breastfeeding looks like. So assisting the mother with breastfeeding, especially the first-time moms, a lot of times they have a hard time with getting that infant to latch. So advantages of breastfeeding helps promote the mother-infant bonding, maintains the infant temperature, um, no infant allergies, and may play a role in brain development. There's a whole list of different things that um, are benefits to breastfeeding. So here's just some different positions. A lot of times it's mom's choice. Sometimes the baby has a preference of how they like to feed. Um, but a football hold is a nice position for when a mom has had a C-section, which is um, B position, because that infant is not laying across their abdomen. So how do you evaluate the intake of an infant? So infant nurses for about 15 minutes per breast, 8 to 10 times per day. They do not need to feed a certain amount on one side and then take the infant off and then feed on the other. Um, that's actually kind of more of an old school way of thought. So they can just feed on one side, and then the next time the mom breastfeeds, they can feed on the other. And sometimes they may go for 45 minutes, or other times they may feed for 5. It kind of just depends on the infant of that certain time. So you want to make sure they have 6 to 8 wet diapers a day, that they're passing several stools, and that their breast feels soft after feeding. That kind of makes it show that, okay, that infant did latch on properly and did get adequate milk. So recognizing those hunger cues in an infant. There's lots of different things. There's hand to mouth movements, sucking motions, rooting movements, and that crying is actually a late sign. So here's just a few guidelines that are good for teaching purposes to the mom if she has questions on storing and freezing breast milk. So milk at room temperature for more than 4 hours increases potential for infection or for bacterial contamination. Milk can be stored in the refrigerator for 24 hours or in a freezer for up to 3 months. Can be thawed in refrigerator for 24 hours, and make sure that you're never breast or microwaving breast milk because it destroys immune factors in the milk. And also, too, as you know, when you microwave anything, my example is always that lean pocket where it's really hot on the outside and still cold on the inside. So it just has that uneven temperature, and actually, you would want to avoid burns from the baby. So, maternal nutrition, they actually need to consume more calories when breastfeeding than when they were pregnant. And they also should make sure they're having an adequate amount of fluid. And then note that some medications taken by the mother may be secreted in the breast milk. So it's important for the patient to always refer to their healthcare provider or pediatrician, whoever it is that they need to go to, on what medications that can be taken. So there's different types of formula feedings. There's ready to feed, concentrated, or powdered. So it's just important to follow that manufacturer's instructions. So these infants do not need to feed as often as breastfed babies. So a lot of times they're fed every 2 to 4 hours. Don't microwave the formula. Don't prop the bottle. You want to make sure you're holding it the whole time when you're feeding the infant. Okay, then discharge planning. That begins at admission. So it gives them plenty of time to ask questions. And then, so due to the quickness of discharge, teaching often begins before the mother is psychologically ready to learn. So you want to make sure you provide sufficient teaching materials for the mother to refer to after discharge. So teaching for self-care, and we'll go over a lot of this teaching in our last simulation lab. We'll go over a lot of details on teaching for mom and baby. You want to give lots of different materials, follow-up appointments, hygiene, diet, exercise, infant safety seats, all that good stuff. Newborn discharge care. It's going to be similar to when you're teaching to mom. So, well, baby checks start around 6 to 8 weeks. You want to give them their immunization information, and then car seat safety. That seat should be in the back seat and facing the rear until 2 years of age. All right, and that is it for the lecture. If you have any questions at all, don't hesitate to email me or we can bring it up in class the following week.